So imagine you're at a comedy club, right? You're having a great time, you laugh really hard at a joke, and, well, immediately you realize you need to leave and change your clothes.
Oh, man, yeah. That is an incredibly stressful scenario.
Right. But for a huge portion of the population, I mean, this isn't just some hypothetical fear. It is the daily, totally frustrating reality of stress, urinary incontinence, or, SUI.
It really is. I mean, it dictates what people wear, how much water they drink before a long drive, whether they can comfortably lift their kids, or even if they feel secure going to a gym.
Yeah, the mental toll must be exhausting.
Absolutely. We're basically talking about the involuntary loss of urine during activities that increase pressure in the abdomen. So like coughing, sneezing, laughing, lifting.
Yeah.
And it affects anywhere from, well, 17 to 45% of adult women.
Wow, that is a massive percentage.
It is. It's incredibly common.
So when you finally go to a doctor to resolve a daily life-altering issue like that, you'd probably expect a single, simple fix, right? Like, here's the surgery for this.
You'd think so, yeah.
But instead, you might actually find yourself handed two completely different surgical blueprints. Blueprint A relies on, like, classic structural engineering. It uses your body's own architecture. And then Blueprint B is this modern, high-tech, synthetic shortcut.
Exactly. And choosing between them, it really means choosing between two entirely different philosophies of how the human body should be repaired.
Right. And to make an informed choice in that scenario, you have to understand not just what these procedures are, but, the underlying mechanisms of why they work.
You absolutely do. You need to know the specific anatomical trade-offs you're making when you pick one over the other.
And that is exactly the mission of our deep dive today. We are going to demystify the surgical treatment of SUI.
It's a great topic. Very needed.
Yeah, we want to understand the classic Burch colposuspension, compare it to the modern mid-urethral sling, and sort of map out exactly when a surgeon will recommend one over the other.
Right, because it's not a one-size-fits-all situation.
Right. Exactly. And to do this, we've pulled together a really dense stack of clinical sources. We're looking at urology department clinical guides, detailed research from the Mayo Clinic, the landmark care and sister clinical trials, and the official NICE guidelines.
That is quite the mountain of medical data.
It is. But our goal is to translate it into a clear map for you. So, okay, let's unpack this from the beginning. Anatomically speaking, what is actually failing when a leak happens?
Well, the texts point to a mechanical failure in anatomical support.
Yeah.
So most often, this is a condition called urethral hypermobility.
Urethral hypermobility.
Yeah, so the urethra is the tube that carries urine out of the bladder, right? And normally it rests very securely on a firm hammock made of pelvic floor muscles and ligaments.
Okay, I'm picturing that.
So when you cough, the pressure inside your abdominal cavity suddenly spikes. If that pelvic hammock is firm, the sudden pressure just compresses the urethra completely shut against it. The system stays sealed.
Okay, let's unpack this with a visual, just to make sure I'm getting it. If we think about the urethra like a garden hose lying on the ground,
Sure, that works.
a healthy pelvic floor is like a solid concrete driveway underneath that hose. If a car drives over the hose, which I guess represents the sudden pressure from a sneeze, the hose gets pinched completely flat against the hard concrete, right? And no water escapes.
Exactly. The backstop is solid.
But with urethral hypermobility, it's as if that concrete driveway has sort of turned into soft mud.
Right.
So when the pressure from a cough hits, the hose doesn't get pinched shut at all. It just gets pushed deeper into the yielding mud.
Right.
And because the hose stays open, you get a leak.
That is a brilliant way to picture it, honestly.
Yeah.
Yeah, the anatomical support has weakened, which, can happen due to childbirth or just aging or even genetic factors.
So things just get loose.
Exactly. The urethra basically drops out of its proper position within the abdominal cavity. The surrounding tissues are just too lax to provide that necessary backstop.
Okay, so if the problem is a muddy, unstable foundation, the logical solution is to, well, pour new concrete.
Right.
But how did surgeons figure out how to do that inside the pelvis? I mean, that sounds complicated.
It is, and that brings us to Dr. John C. Burch. He developed this really groundbreaking procedure back in 1961.
1961. Okay, so this has been around a while.
Oh, yeah. For half a century, the Burch colposuspension was the absolute gold standard for curing SUI.
Wow.
And it is an entirely mesh-free procedure. The surgeon basically uses permanent sutures to lift the tissues surrounding the bladder neck back up into their proper retropubic position.
So they're physically hoisting it back up.
Exactly. They're pulling the urethra back up into the higher pressure zone of the abdomen, so it has that firm floor to compress against again.
Okay, but the details on this in the surgical guides we looked at are incredibly dense.
They really are. It's a complex surgery.
Yeah, the texts say the surgeon places permanent stitches into the anterior vaginal wall, excluding the vaginal skin itself, and then they anchor those stitches to something called Cooper's ligament.
Right, the suspension part.
And it stipulates they must be placed exactly 4 centimeters lateral to the pubic tubercle. I mean, for those of us without an anatomy textbook open in front of us, where exactly are we operating here?
Okay, let's orient ourselves. So the pubic tubercle is a small, bony bump on your pubic bone, right at the front of your pelvis.
Okay, got the bump.
And Cooper's ligament is this very thick, super tough band of fibrous tissue that runs right along the top of that pubic bone.
So it's basically a bony ridge with a thick band on it.
Exactly. Think of it like a heavy-duty structural beam that's just built into the pelvis.
Ah, okay.
The surgeon is taking the loose, sagging tissue around the vagina and bladder neck and using stitches to hoist it up and literally tie it off to that rigid, bony beam.
Okay, I see. And the precision there, that exact 4 centimeters to the side of that bony bump, is crucial because I assume pulling the tissue straight up the middle would just completely distort the anatomy, right?
Exactly. You have to lift it from the sides to create a flat, stable surface, a new floor.
Right, but okay, reading through the surgical principles for this, I hit a concept that seemed completely counterintuitive to me.
Oh, which part?
The clinical guides emphasize over and over that when the surgeon ties those sutures to the structural beam, the overriding principle is, and I quote, "looser is better than tighter."
Yes, that is a massive rule in this surgery.
But they describe aiming for a tension-free, floppy suspension. I mean, if the entire goal of the surgery is to stop a leak, wouldn't a surgeon want to tie that hose down as tightly as possible to guarantee no urine gets out?
It seems like it, right?
Yeah.
But what's fascinating here is that the human bladder is a very delicate, low-pressure system.
Okay.
If a surgeon ties those stitches too tightly, they aren't just creating a backstop, they are actively strangulating the urethra.
Oh, wow. That sounds bad.
It's very bad. It leads to a severe complication called urinary retention. The patient wakes up from surgery and physically cannot empty their bladder at all.
Oh, no.
Yeah, it requires catheters and potentially even more surgery just to undo the tension.
So you've essentially just swung the pendulum completely in the opposite direction.
Exactly.
From leaking everywhere to a total blockage.
Right. The goal of the Burch procedure isn't to permanently clamp the urethra shut. The goal is just to provide that floppy, tension-free floor for the urethra to rest against.
Oh, I see.
During normal daily activities, it just hangs out there loosely, allowing the patient to empty their bladder normally when they choose to.
Right, because there's no pressure on it.
Exactly. It only provides resistance in that split second when intra-abdominal pressure spikes, like during a heavy lift or a cough, which forces the urethra down against that newly constructed floor.
Okay, that makes perfect sense. You're just rebuilding the floor, not installing a clamp. That logic is really sound.
It is, which is why it was the gold standard for so long.
Right, for decades, the Burch was the king of pelvic surgeries. I mean, it's structural, it relies on the patient's own tissue rather than foreign implants, and it boasts long-term success rates hovering between like 70 to 85%.
Those are solid numbers.
They really are. But it is also a major surgery. It requires deep pelvic access. So if the Burch was that successful, what drove the medical field to look for an alternative?
Mostly the search for efficiency and a lower surgical impact.
Okay.
A traditional Burch requires either a large open incision in the lower abdomen or a really complex laparoscopic approach with multiple small incisions.
Both of which sound intense.
They are. Both require general anesthesia, significant operating room time, and a pretty decent recovery period. So in the late 1990s, the medical community started shifting toward a new standard.
Blueprint B.
Exactly. The mid-urethral sling, specifically the tension-free vaginal tape, or TVT.
Right, the TVT sling. And this operates on a totally different mechanical principle, doesn't it?
It does.
Because instead of hoisting the whole vaginal wall up to a bony ligament, the surgeon takes a thin strip of synthetic plastic mesh, right?
Yes, a tiny strip of mesh.
And they pass it through small incisions to create a tiny hammock sitting right under the middle third of the urethra.
Exactly. It basically acts as an artificial ligament.
But what absolutely blew my mind reading these clinical notes is that the sling often doesn't even use stitches to hold the mesh in place.
I know, it sounds crazy.
It really does. If there are no stitches anchoring it, How does a piece of plastic mesh not just, like, migrate around inside the body?
Well, it relies on tissue integration and friction.
Friction.
Yeah. The synthetic mesh isn't smooth. It has a very specific porous texture to it, almost like Velcro.
Oh, okay.
During the procedure, the surgeon uses special tools called trocars to create narrow, really tight tissue canals behind the pubic bone.
Okay.
When the mesh tape is threaded through those tight canals, the strong friction grips the rough texture of the tape,
So it just sticks.
pretty much. And then, almost immediately, the body's own tissue begins to grow into the pores of the mesh, basically locking it securely in place without the need for any fixation sutures.
Wow. So that completely eliminates the need to meticulously sew deep inside the pelvis.
Exactly. It's so much simpler.
And comparing the surgical times and the trials we reviewed, I mean, the difference is stark.
It really is night and day.
A laparoscopic Burch colposuspension takes about 132 minutes on average, but the TVT sling procedure, only 79 minutes?
Yep.
It's almost twice as fast.
It is faster, and it can often be done as an outpatient procedure, meaning the patient just goes home the exact same day.
That's incredible. And looking at the meta-analysis data, the sling isn't just faster, it boasts slightly better objective cure rates too.
It does.
Reviews show nearly 4 out of 5 patients achieving complete continence with the sling, compared to roughly 2 out of 3 with the Burch.
Right, the numbers definitely lean toward the sling.
Yeah, long-term studies consistently place the sling success rate in the low to mid-80s. So faster surgery, a quicker recovery, no complex suturing, and slightly better leak prevention.
It sounds perfect, right?
It looks like an absolute blowout victory for the synthetic sling, which makes you wonder why a patient would ever choose the invasive classic Burch today.
Well, the clinical landscape is unfortunately never that simple.
Right.
Just when an intervention seems flawless, we have to look at the complication profiles. And in the case of synthetic mesh, we also have to navigate a massive social and regulatory controversy.
Which is actively bringing the classic Burch procedure back into the spotlight.
Exactly.
So we need to discuss the mesh controversy. And just a quick note for you listening, our aim here is to neutrally report on the clinical data and the regulatory environment as it's outlined in the medical sources. We're not taking sides.
Right.
But the public backlash against medical devices has completely altered the landscape of patient choices, and understanding that context is absolutely vital.
It really is. Over the last decade or so, there have been sweeping FDA warnings, massive class action lawsuits, and just intense global public scrutiny regarding transvaginal mesh.
Yeah, it was everywhere in the news.
But it's important to distinguish that most of the severe complications driving this controversy were actually centered around large sheets of synthetic mesh used to repair pelvic organ prolapse.
Right, not the SUI slings.
Exactly. Not the very small, narrow strips used for SUI slings. They are a different application entirely.
But to the general public, mesh is mesh.
Exactly.
The fear of synthetic materials integrating into sensitive vaginal tissue, potentially causing chronic pain, infection, or, the mesh actually eroding through the vaginal wall, has heavily impacted how patients view the mid-urethral sling.
Understandably so.
Right. In several countries, synthetic meshes for pelvic surgery have faced severe restrictions or even outright bans.
Which is wild. This public and regulatory pressure has essentially forced the urological and gynecological communities to renew their interest in the mesh-free traditional Burch colposuspension.
Because they need a backup plan.
Right. But beyond just the public fear of mesh, the clinical sources highlight very real medical trade-offs between the two procedures.
Okay, let's get into those.
The sister trial provides a massive amount of data here, mainly because it directly randomized patients to receive either a sling or a Burch.
The sister trial really puts the side effect profiles into perspective.
It does.
While the sling was slightly better at stopping the leak, the complication rates were pretty eye-opening. Like, let's look at voiding dysfunction and urinary retention, that issue we talked about where the patient physically can't empty their bladder.
Right.
Patients were 7 times more likely to face urinary retention with the synthetic sling than with the Burch.
7 times. That's huge.
Yeah.
And the sling also triggered a much higher rate of something called de novo urge incontinence.
Novo meaning new, right?
Exactly. And this is just a cruel irony for a patient seeking treatment for leaking.
I can imagine.
They go in to fix stress incontinence leaking when they cough, and they wake up with a brand new problem. a sudden, uncontrollable urge to pee that they didn't even have before the surgery.
Oh, that is awful. Roughly 1 in 4 sling patients develop that new urge incontinence compared to 1 in 5 Burch patients.
Right.
But why does the faster, seemingly simpler sling cause these specific issues so much more frequently?
Well, if we connect this back to the anatomy, the bladder and urethra form a highly sensitive pressure system.
Okay.
The sling involves a foreign, synthetic material resting directly against the middle of the urethra. And even if the surgeon places it loosely, as scar tissue forms around the mesh, it can contract and harden.
Oh, because the body is reacting to it.
Exactly. This localized stiffness can easily swing the pendulum too far into urinary obstruction.
Right, it gets too tight.
And then the bladder muscle has to work much harder just to push urine past that stiff mesh barrier. That overworking of the bladder muscle is exactly what leads to spasms and the sudden, uncontrollable urge to pee.
Okay, so the sling fixes the leak better, but you are trading that for a much higher risk of not being able to pee or suddenly needing to pee all the time.
That's the trade-off, yeah.
The Burch is much safer for your normal urination dynamics. But, let's look at the complications of the Burch because it isn't perfect either.
No, definitely not.
The Burch carries a much lower risk of urinary obstruction and an incredibly low risk of accidentally puncturing the bladder during surgery.
Right, which is a risk with this sling.
However, the sources note that the Burch is slightly, and this is a weird phrase, prolapse-inducing over time.
Yeah, that's a Q factor.
Meaning it actually causes other pelvic organs to drop out of place.
Specifically, the posterior wall, so the back wall of the vagina. Patients who had the Burch were roughly 3 times more likely to need a follow-up surgery years later to fix a prolapse compared to the sling patients.
3 times more likely. The mechanics of why a surgery on the front of the pelvis causes the back of the pelvis to collapse were really hard to picture until I thought about a pop-up tent.
Oh, I like that analogy.
Yeah, imagine a fabric pop-up tent. If you grab the front canvas wall and pull it incredibly tight to peg it to the ground, the tension alters the whole structure, right?
Right, it pulls everything else out of whack.
Exactly. The opposite side of the tent, the back wall, is going to lose its structural integrity, sag, and eventually collapse inward.
That is exactly what happens to the vaginal walls. By pulling the anterior wall up and forward to anchor it to Cooper's ligament, you are fundamentally altering the dynamic tension of the entire pelvic floor.
And leaving the posterior wall vulnerable to sagging.
It's an issue of shifting the biomechanical load. You are solving the urethral drop, sure, but leaving the back of the vagina unsupported against the daily pressure of gravity and lifting.
So how does a patient navigate this? Do you risk the urinary retention of the synthetic sling? Or do you risk a prolapsed posterior wall 5 years down the line with the Burch?
It's a tough call.
How does a surgeon even know if a patient needs the pop-up tent adjustment or the mesh hammock?
Well, it really comes down to highly individualized patient selection. And this is driven by a preoperative diagnostic test called urodynamics.
Urodynamics. Okay, what does a urodynamics test actually look like for the patient?
It's a very interactive, in-office procedure. The doctor basically places very thin catheter tubes into the bladder and the vagina or rectum.
Okay, sounds slightly uncomfortable, but necessary.
Right, and these tubes have pressure sensors on them. The bladder is slowly filled with fluid. Once it's full, the patient is asked to bear down, kind of like they're having a bowel movement, or to cough forcefully.
Okay.
The sensors measure exactly how much intra-abdominal pressure it takes to overpower the sphincter and cause a leak. This is called the Valsalva leak point pressure.
So it's literally recreating the comedy club sneeze, but in a controlled clinical environment to measure the exact breaking point of the plumbing.
Exactly. Urodynamics tells the surgeon exactly how the continence mechanism is failing.
Ah, I see.
If the test shows standard urethral hypermobility, so the garden hose sinking into the mud because the floor is weak, then rebuilding that floor with a Burch is a fantastic, highly durable option.
But what if the test shows the floor is actually fine, but the hose still leaks? What is failing then?
That points to a condition called severe intrinsic sphincter deficiency, or ISD.
ISD. Okay.
In this scenario, the internal valve mechanism inside the urethra itself is degraded and weak. It's not just a support problem. The hose itself is actually broken.
Oh, wow. So lifting it wouldn't help.
Exactly. For patients with severe ISD, the Burch colposuspension often fails. Simply lifting a broken valve up to a new ligament doesn't magically make the valve close any tighter.
That makes total sense. So in cases of severe ISD, the mid-urethral sling is objectively the better choice.
Usually, yes.
Because that synthetic mesh tape provides the necessary artificial resistance right under the degraded part of the tube, creating a sort of kink that keeps the broken valve closed when pressure hits.
Right. Urodynamics really acts as the ultimate tiebreaker here.
But beyond the diagnostics, the Mayo Clinic research and the clinical guides highlight 3 specific scenarios where the classic, old-school Burch procedure is still the undisputed winner today.
Yes, and these are important to know. The first scenario is when vaginal access is severely limited.
Because of scarring or something.
Exactly. Because slings are placed transvaginally working through the vaginal canal. A patient with heavily scarred, shortened, or narrow vaginal tissue is at high risk for complications with a sling. Going in from above via the abdomen to perform a Burch is just much safer in that case.
That makes sense. And the second scenario is when synthetic mesh is strictly contraindicated, right?
Yes. A patient might have an autoimmune condition, a history of rejecting implants, or simply a strong personal preference to avoid synthetic materials altogether due to the public controversy we discussed.
Right. And the third scenario is the one I found the most interesting.
Oh, definitely.
It's when intra-abdominal surgery is already planned for another reason. This brings us to the CARE trial, which is just a massive piece of literature in these surgical guides.
The CARE trial really changed how surgeons approach pelvic reconstruction. It looked at women who were heading into the operating room for a sacrocolpopexy.
And that is a major abdominal surgery used to fix apical pelvic organ prolapse, right?
Exactly, which is when the very top of the vagina or the uterus drops down into the vaginal canal.
Okay, but the fascinating part of the trial design is that the women they studied didn't even have symptoms of stress urinary incontinence before the surgery. They weren't leaking when they coughed at all.
But pelvic floor surgeons knew from experience that fixing a massive prolapse often unmasks hidden incontinence.
Hidden incontinence.
Yeah. The large prolapse was essentially kinking the urethra shut, naturally hiding the leak. Once you pull the prolapse back up into place, the kink is gone, and the patient starts leaking urine during recovery.
Oh, wow. So fixing one problem creates another.
Exactly. So to study this, the CARE trial randomized the patients. Half got just the prolapse repair, the other half got the prolapse repair, plus the surgeon performed a prophylactic or preventative Burch colposuspension at the exact same time.
Because they're already in there.
Right. Since the surgeon was already operating deep inside the retropubic space, adding the Burch only added a few minutes to the total surgery.
And the results were definitive. Adding that preventative Burch dropped post-operative SUI symptoms from over 45% down to just 32% at the 2-year mark.
It's a huge drop.
And crucially, doing the Burch didn't increase the rates of urinary retention or the urge incontinence that we saw with the slings.
Right. It basically proved that if you are already operating in that retropubic space, taking the extra time to do a Burch is an incredibly safe and effective way to protect the patient from future leakage.
All without introducing any synthetic mesh into the body.
Exactly.
So if you are that patient sitting in the doctor's office staring at those 2 surgical blueprints, being well-informed means realizing there's absolutely no one-size-fits-all miracle surgery.
None at all.
The marketing brochures might say the quick 79-minute sling is a silver bullet, but your personal anatomy, your urodynamic test results, or a planned prolapse repair might dictate otherwise.
It is entirely about matching your unique presentation and your personal risk tolerance to the right mechanical tool.
Totally. So, to summarize this deep dive, the Burch colposuspension is your classic, time-tested, mesh-free structural lift. It uses your own tissue, avoids foreign body complications, and is brilliant if you're already having abdominal surgery or want to avoid synthetic implants.
Though it does carry a slightly higher risk of future prolapse.
Right. And then the mid-urethral sling is your modern, highly effective, fast synthetic support that acts like an artificial ligament. It offers a slightly higher objective cure rate and a faster recovery.
But carries a higher risk of urinary retention and new urge incontinence.
Exactly. Both procedures have strong, proven long-term outcomes when applied to the right patient.
They do. But this deep dive really raises an important question about the future of urological surgery, doesn't it?
It really does.
As patient advocacy groups continue to voice concerns about synthetic meshes, and as more regulatory bodies ban certain products, surgical training programs are having to aggressively pivot.
I didn't even think about the training aspect.
Yeah. For a long period, surgical residents were primarily learning the fast, efficient sling procedure. It was just the standard. Now they were being forced to ensure the complex, anatomically demanding Burch colposuspension stays alive and well-practiced in their repertoire.
Which is honestly a huge win for patient choice and safety. We need surgeons to know how to do both.
Absolutely.
I want to leave you, the listener, with a final provocative thought to ponder. We've spent this whole time comparing tying permanent stitches to bony ligaments versus implanting synthetic plastic mesh into tissue.
Right.
But both blueprints have severe mechanical limitations. The Burch can pull too tight, acting like a badly pegged tent and causing prolapse. The synthetic mesh can cause scarring, stiffening, and urinary obstruction.
Because they both rely on static, inanimate materials to fix a highly dynamic living pressure system.
Exactly. So what if the future of treating stress urinary incontinence abandons both of these physical blueprints entirely?
Oh, I like where this is going.
Imagine a future utilizing stem cell therapy or tissue-engineered biological supports. A localized treatment that dynamically integrates with your own tissue, literally regenerating that firm, muscular pelvic floor from the inside out.
That would be incredible.
Right. The mud turns back into concrete naturally, so the garden hose works perfectly again. It would cure the leak without any risk of synthetic scarring, permanent obstruction, or structural prolapse.
It really is the next true frontier of reconstructive medicine, moving away from structural scaffolding and moving toward actual biological regeneration.
Let's hope we get there soon. But until that day arrives, we have to rely on the surgical blueprints we currently have.
We do.
Hopefully, if you ever find yourself handed those two options, you'll know exactly what questions to ask your surgeon and exactly what kind of foundation you want to build.